Hi everyone, my name is Nadine Sharples. I'm currently the chair of the
You're not
Paediatrics
listening.
Clinical Exam Committee. Welcome. We've got a session for those of you who've been brave enough to be the local exam organiser, also known as the LEO. And with me, I have the team from the assessment services, and I also have Dr. Drago Bratkovic from South Australia, who is the deputy chair. So he'll be correcting any mistakes that I make as we go through the session. If we could go to the agenda, please. So firstly, thank you all for joining us, and we're going to give a bit of an overview of what's going to happen in the next couple of weeks, what you should be looking out for as we get towards organising your exam day. So firstly, in terms of starting the meeting, I would like to acknowledge the traditional owners of the land in which we meet. I'm not sure if I've got control. No, I haven't got control of the slides. Could we go to the acknowledgement of country, please? So we acknowledge the traditional owners and custodians of the lands on which we live and work. We extend our respect to all Aboriginal, Torres Strait Islander and Māori people and value the importance of their ongoing connection to land, sea, sky and community. And we pay our deepest respect to elders past, present and emerging. And together we restate our shared commitment to advancing Aboriginal, Torres Strait Islander and Māori health and education as core business of the RACP. So tonight is really about what the clinical exam is, its purpose. So it is to assess the clinical skills, the clinical acumen and the interpersonal skills to inform whether the trainees have reached the standard for completion of basic physician training. And how I often think about this is, are they going to be a safe registrar in advanced training? And we would like you to be very involved in the session. So if there is any questions, perhaps you can either put it in the chat or put your hand up. Unfortunately, I can only see a small number of you online, so it's probably easy if we pop it in the chat. Next slide, please. So the key dates. So as you would be aware, I'm sure many of you have had trainees who are nervously waiting on their results, which come out on the 13th of March. And they have a 1-week period to apply for the clinical exam, and that will determine our numbers for Australia with those sitting the clinical exam. It will also mean that our final candidate numbers at each site will also be determined. But we also have quite a short window for the candidates to make their applications, and that's so our assessment services team and the RACP team can actually do all the allocations so that the trainees then get adequate time to know where they're going, to plan their travel and all of those things. So we've got a couple of things there talking about applications for special consideration, and we will be talking about this a little bit later on with regard to the special consideration policy, but it's something as a LEO you should be aware of. And of course, the exam date. So we're kicking off on the 16th of May and finishing on the 1st of June. And then we've got a 2-week period where the results will be reviewed and the results will be released during the week of the Monday, 16th of June. Next slide, please. So this is contingency plans. We've obviously had this with COVID in the past. Fingers crossed we're not going to have anything too awful happen this year. I do note, however, in the US that there's been a big influenza surge, so fingers crossed our winter's not going to be that terrible. But if there is something, there is a plan B, and impacted candidates may be reallocated to other local available exam sites. So one of the things that us as a committee have been quite involved in is talking about ensuring the candidate's readiness to undertake the clinical exam. We have updated the terms and conditions, and the candidates must agree to these when they are applying for the clinical exam. So the special consideration policy, there's a good link there, and you can look at that. And I think it's worth looking at it in detail with regard to what is an appropriate pre-exam special consideration. So we would look at that, and so if a candidate had a hearing impairment and needed an augmented stethoscope, that's an appropriate pre-exam condition. Equally, breastfeeding mothers or those with pre-existing medical conditions, so like a diabetic who needed snacks or needed insulin, those types of things. But post-exam considerations, they are usually going to be technical issues that occurred during the day or a procedural incident, and they must be filed within 5 days of the exam. Things that won't be considered, and I think this is what we probably would want everybody to be aware of. So things like the stress of the exam, an upheaval in your personal circumstances, or a medical condition that was probably not well controlled or not managed appropriately. Those things are really down to the candidate to make a call as to removing themselves before the exam. So if the candidate does decide to not attend the exam, then the exam won't be counted as one of their attempts. However, should they start the exam, then it will be counted as an exam attempt, and any results will stand. So the other thing to make sure that the trainees are aware of is that any results are final, and we will not be changing marks. There will be things in the special consideration policy that we will look at, and so the outcomes of our review of those special considerations may be things like the exam attempt is not counted, or there may be a reimbursement of fees. But if there is a negative result, then that will not change. Drago, have you got anything to add to that?
No, I think you've done a really good job there. I think it's really important to stress that. And I think it's for the DPEs as well as the LEOs to be aware of the situation there. And so if someone turns up that day and is looking awful and not looking really good, I think it's within your rights, and probably something you should do is actually talk to them and say, do you really want to go ahead with this today? And give them that one other opportunity to withdraw from the exam and not have it count. And how much you get back from your fees depends on when you withdraw from the exam. I can't remember exactly when you can get 50% off, and then
weeks, I believe.
Within, pardon?
Weeks. I think it's half
yeah. Exactly. That's right. And so just making sure people are aware of that and to withdraw. And we don't want people to go through the stress of the exam if they're not ready. I think that's something that, we as doctors, we try to push on with these things, but sometimes you just got to say, look, I'm not ready for this, and I should take my time.
Yeah, I think that's right. And also, we'll be talking with the DPEs later on, and I note that many of you are already here, but I think that's something that we should actually be ready to have a conversation with our trainees about if we feel that they're not adequately prepared. Next slide, please. So I'm sure many of you are aware of this, and you can see the exam format and have thoughts about it yourself. I personally have just stopped having dreams about my own exam day quite some time ago now. But you have 2 long cases, and the candidates have 60 minutes with the patient. They have a 10-minute preparation time. And I think the one thing to be aware of here is ensuring that the candidates know that it may not be the full 10 minutes, because there will be time getting out of the room, getting to the note preparation area, and then to the examiner's office or room. So just to be aware there. And then 25 minutes, obviously, with the examiners. And of course, we have 4 short cases, 2 in the morning, 2 in the afternoon, and a 2-minute reading time outside the door reading the stem. And the examining team may be one national examiner or senior examining panel member, a local examiner, and if you're lucky and have got lots of keen young people, we would love to have a provisional examiner as well. Thanks, Stephen. Will the presentation be shared afterwards? I believe that it will, and we are currently recording. So thank you for that. Next slide, please. So the next couple of slides are all very busy.
I might just emphasise that point you made earlier on, Nadine, about that 10-minute reading time. And I always say to our candidates in Adelaide and South Australia that don't count on 10 minutes, count more on just maybe 5 or 6 or 7 minutes to take into account that movement. And one of the biggest things that we always get as incidents on the day is that when they pay candidates, or problems that we have is the candidates being late to present their long case because they're kind of just rushing and they're trying to do those last minute kind of preparations. And that always detracts from them, the actual presentation that they do, because they usually come in quite flustered and not quite ready. So I think making sure candidates are aware and during all the practice ones that really don't give yourself only 5 minutes. Don't think you've got 10 minutes.
Yeah, great point. Okay, so these next couple of slides are quite busy, and you will receive a copy of the Leo manual on the SharePoint, which will be labelled version 2 for the most up-to-date one. So these will look at how the examiner's day looks, and you can see we all arrive very bright and early at 7:35, and then we see our first patient at 8:10. So we have a 40-minute time with the family, and then with our co-examiners, we tend to get our management priorities sorted out and assess and update the digital score sheet. And then we move to the short case, reviewing the short case patient. And then very quickly, soon thereafter, the first candidate arrives for us to start with at 9:40. So you can have a look at those timings in detail, and they will become almost second nature to you by the time you've organised everything. But if we could move to the next slide, please.
Nadine, I might just highlight the morning tea break and the lunch break,
Yes,
how much time there is for us as examiners for those. Morning tea break's only 10 minutes. It's a really quick turnaround for us. And similarly, lunch is only 30 minutes. And so some centres that we've examined at have brought morning tea to the examiner's rooms, and we've really appreciated that. I think consider doing that for your centre would be really good. Lunch for 30 minutes, it's usually enough time for us to go to a separate room and have lunch there. So that should probably be what you do, but maybe give people the option to have lunch in their the examiner room, because we're frantically trying to type in feedback after each of those sessions. So a little bit of extra time for us to do that is always greatly appreciated.
I think that's a really good point. And yes, thank you to those centres who have very kindly provided morning and afternoon tea in our rooms. I think particularly if on the day there is if you know that one of the examining teams has had an issue, that there may have been a delay or something's happened, it might be worth checking with them whether they would like their lunch in their room. So looking at this next schedule, so this is the candidates who have the long case first. So they start at 9:30 and they go through the day with their long case first, 2 short cases, lunch, and then they will have the reverse order for the afternoon. So they'll finish on their long case. And then the corollary of that is that at 9:38, the candidates starting on the short cases commence their reading and they have their 2-minute time there, and then they'll see the first case at 9:40. So again, you can familiarise yourselves with these. I'm not going to go through them, but It will all be in the handbook, and you'll get lots of information about that and how it will all look over the next couple of weeks. Next slide, please. So I guess the thing that most Leos are really interested in, and for those of you like Mackay, who are hosting for the first time, and thank you so much for that, is what makes a suitable long case. So we want something with active problems or diagnostic or management problems. So they should probably have other stable conditions that need to be assessed by the candidate. And the patient ideally has some significant physical signs present. So children with cerebral palsy, obviously, or a developmental long case are often, well used, and the families are usually very well versed in the history as well. And that's a really important point as well, is that the family need to be very good historians. So because they're not bringing in anything. And I think when you're consenting your patients to be part of the exam, some families will ask, oh, what do I need to bring on the day? Well, we don't want them to bring anything. This is the history from the families as they recall it. What happens when that poor child with cerebral palsy gets a lower respiratory tract infection and is not well enough to attend on the day? Well, hopefully you will have recruited about 25% extra reserve patients. But if they get sick too, then patients on the ward can also be suitable. So I think if you can find a patient with similar things, that would be great. But all is not lost if you do get some patients pulling out. And yeah, trawling the wards can be very helpful the night before for you as a Leo, so that you've identified those patients. Yeah.
I was going to suggest that you should go around the wards and find out what patients are around and who could be on case, and actually consent them that night before, so you can just bring them down straight away, because believe me, you might not have much time if someone doesn't turn up.
The other thing to say is that when you're inviting the families to attend, they need to be aware that they need to be with us for at least 4 hours. And so the morning candidates have to be there, I think, about 7:30 as well, so at the same time as the examiners. And they should also be aware for the long cases that they're going to be seen by the examiners, and they're going to be seen by 2 candidates. So they're going to need to go through their story 3 times. Equally, when we talk about the short cases, they're going to be examined 5 times. So they have to be prepared to participate for the full morning or the afternoon cycle. The long cases, when you're preparing your summary for the examiners, you don't need a huge amount of detail. It's going to be a list of active problems and other management issues. And we don't need investigations. A lot of what we do and we get the issues, a lot of it's going to be something in the social history or the family history. So there's a lot of things that we'll talk about there. Next slide, please.
Just to emphasize that, not to spend too much time on that, because I think if I look at all the examiners I've examined with over the years, rarely will any of us actually look at that problem list.
Yeah. And I think that's the other thing. It's like, it's really good though that you are aware of what the patient has, but sometimes we find different things, or there's a different focus for that patient when we take the history. But yeah, I agree. Don't spend ages and ages trawling through the case files. So the short cases, they ideally long-standing physical signs that can be clearly detected by careful examination. And I was telling our trainees on the weekend when we had our boot camp, is that, if one of us hears a click and the other can't, then that doesn't, like, those kind of really subtle things, that's not going to be a finding that we really feel is essential for that candidate to pass. So And the other thing is that we would love clear signs that are not likely to have disappeared by the day of the examination. So, you know, a very dense pneumonia or pleural effusion, often they will have resolved by the time that you see them on the day. And for the candidates, when you can't find the signs, it's very anxiety provoking for them, and it's very challenging then for us as examiners to be able to get them to perform really well and score really well. The other thing to say is it's lovely if you have cases like a Russell-Silver, but I really don't want to walk into a room and say, oh, it's a Russell-Silver syndrome. This is more, we want to know how the candidates will approach something like a short stature, and then they can work their way through the differentials. So spot diagnosis doesn't make a great short case. And again, it makes it very hard for the examiners to come up with good questions. We are the ones that create the STEM. So in your packs that you'll get from the college, there'll be a template of the STEM. You don't need to write anything on there. If you can just leave that blank, but if on the envelope you leave for us, if you could write the name of the child, their age and their gender, preferred pronouns if appropriate, then that's all we need, and we'll create the STEM from there. And the body system, that's also usually quite helpful for us as well. Yeah.
Just the other thing like advice in terms of where to spend your time, because you'll be kind of time poor, I think, leading up to the exam. You'll be very busy with lots of other things. In terms of investigations, people provide investigations to us. I think it's really important to think what is going to be important and what's going to be used. For cardiac cases, ECG, chest X-ray are the two main go-tos for that. For, you know, short stature examinations, it might be a bone age, or it might be a chromosome, or, you know, something like that. If you've got a test that is really diagnostic, like a chromosome test or a genetic test, then what we've tended to do in Adelaide is actually put them into a separate envelope and say, this is the result in here is, we'll give you this away, so the examiners can choose whether or not they want to open that and have a look at that. That's just a little trick that we've been doing in the last few years.
That's a really good tip. I like that, because often I will find if we get those chromosome results, and you know, there's quite a lot of information in those tests, and we find that the candidates get overwhelmed trying to read them, and so then if we try and fold them, the candidates will undo them and try and see what they're missing. So it does sort of add to the angst there. So yeah, just be really clear on what you think we want the candidates to have a look at. Next slide, please. Oh, so we're talking about reserve patients already, but it's vital to have a selection of reserve cases so that you can swap like for like. So if you are lucky enough to have have a number of cerebral palsy children with a hemiplegia or a diplegic gait, then you can swap those two if you can, because obviously some of the feedback over the years has been that some candidates have received 3 cardiacs and a developmental, or they've received 2 long cases that are very similar. So trying to get the balance of the grid right is something that your regional examiner can help you with. And there is a spreadsheet that will also be provided in your pack, which actually makes it really easy to slot those patients in. And that is also explained in the Leo manual. But a good rule of thumb is to have at least 25% both long and short cases in reserve. Okay, moving on. So this is, again, tips for patient selection. Actually, I think I have also sort of touched on most of these, but you'll see there's the grid and how you can slot those candidates and patients in. Some states are very lucky if they are part of a network where you can share patients. So I know here in Victoria, the Victorian Leos have a WhatsApp group, and there is the possibility of sharing patients, which worked really well for us last year. So it's great for those families if they are living more regionally rather than having to come to their tertiary centre. But again, if you're not sure about the suitability of a patient, have a chat to some of the national examiners or the senior local examiners in your hospital. That can be really helpful with that. And I have already started contacting the other heads of department in my hospital just to get consultants already thinking about patient recruitment and thinking about families that they might feel would be appropriate for the exam. So I'd probably start thinking about that now. Next slide.
Might jump in here just a little bit, but I think this is, of all of the things, apart from recruiting patients, this is the hardest bit to get right, is to get the balance right. And you'll be constantly moving patients between groups and between rooms to try and get that balance right. And then, of course, you've got dropouts, which then will compound the challenge of trying to get this balance right. But it is really important, and it's one of the things that we, as Nadine has already mentioned, that we get complaints or concerns raised by candidates is the balance on the day. And we know it's hard, it's difficult, but you know, it's important that we try as hard as we can to get it right. We all know that that's what everyone does. Yeah, it's like I said, it's compounded by people not turning up or patients dropping out at the last minute.
Next slide, please. So room setup and map, and you will be asked to provide this in the next few weeks. It's really important that there is a desk and chair available for the candidates to use in their long case writing up area. Now, that if you have access to a big clinic space and there's enough rooms for the candidate to have a room, that's fantastic. But equally, if it is in a corridor or a transit area, that's equally fine, as long as they have a desk and chair. So the other thing which makes it challenging is if the candidate has to walk a significant distance. And I think maybe a year or two ago, we, for whatever reason, there were candidates having to see the patient on one floor and then had to go up in the lift to present to the examiners. And again, it is just adding to the angst for the candidate on the day. So if you do have the ability to make that distance as short as possible, that would be really helpful. Remembering your own experiences, I think that if you can do it, that would be wonderful. The short case room should also be in the same general area and adjacent to the examiner's rooms. Myself, I tend to stay in the room when I'm marking a short case because we just don't have the luxury of time anymore, and we're, you know, frantically typing on the digital score sheet. So having the examiner room for the long case, where the candidate comes and presents, having those two rooms closer together is better rather than being right next door to the short case. But I think perhaps the best advice I can give you in this situation is to actually look at your clinic space and think about what is going to be best for your candidates in terms of transiting. Anything to add there, Drago? No? No? Okay, great. Medication lists. So obviously, as you're trawling through all of your hospital files, you'll create a list, and one will be taped down to the desk in the long case room. The candidates will get a loose copy of that. So if you can have two of them, that would be ideal, because obviously there'll be two candidates. And the medication list is a guide only. So since you guys compile the list, things may have changed since their last outpatient appointment. So, and we request that you use the long case medication list template there. So, and that will come in your pack as well. Next slide, please. So, documentation. So the things that we also ask for, so obviously growth charts. The candidates will often bring their own growth charts, but the examiners, we don't have that luxury of bringing everything with us. If you could provide those for both the long and the short case, that would be ideal. And in terms of imaging, to make it as fair as possible, if we can have a hard copy of the either the chest x-ray or the MRI, however you want to do it, whether it's a physical film or, as everything seems to be computerized these days, if you can have a screenshot of the image or an export of the image and have it as either a Word file or an image file on the desktop of the computer that we can have easy access to. So, and we'll probably talk about this in a couple of emails later on, but having access to your local network, so at least a login and a password so that we can access those digital files quickly and easily for the candidate is probably the best way forward. But I still remember trying to interpret a CT brain, and the photocopy or the printout really was pretty awful, and you really couldn't tell grey-white differentiation because the toner was so bad. So that's just a really helpful thing for the candidates as well as us. The other thing to say is that there's been a decision made that no oxygen saturations will be given to any patients. So whether it's a cardiac case or not, we're just not providing them. And so what we want the candidates to do is to make an interpretation of whether the patient looks cyanosed or not. And the only vitals are the ones that the candidate can take themselves. Moving on, please. Oh, so exam assistants, again, this will show you what the movement looks like when they are escorting the candidates along. Again, you can look at this in detail later on. I think the most important thing, sorry, moving on please with the slides, is that the exam assistants need to have a really good briefing on what to expect on exam day, and they should also be orientated to your clinic prior to the day of the exam. So usually the week before, if you can have a session with them and make sure that there is a copy of, that you have a copy of the assistant's information sheet so they're very clear on what they're able to do. The examination assistants, interestingly, New Zealand doesn't have them, but we do. The examination assistants are there to escort the candidates. They can carry their bags. They can be a source of calm for the candidate, but we ask that they do not participate in the exam. And we had a number of incidents last year that were very disruptive to the exam process. So I personally saw candidates exam assistants wearing timers on themselves, and other exam assistants leaning in with timers and were actually impinging examiner vision and really distracting from us being able to appropriately examine the candidate. So they are not to even hand the candidate any equipment. The candidates have to request that, because you can imagine that some candidates would be thinking some exam assistants would thinking they're very helpful to the candidate and start to hand them the developmental kit or hand them the tendon hammer. So we want the candidate to initiate that kind of thing. Next slide, please. And again, this is something that we'll get you to get them to sign as they sign in on the day. So this is the candidate participation agreement. And again, in the interest of time, we'll get you to to read this at your leisure, but essentially they must maintain academic integrity. They need to give you all of their manila folders and any of the documentation or paperwork that they use during the exam, so that nobody is at a disadvantage going forwards. So so you need to get them to sign this prior to the start of the exam and send them to the assessment services via email, which is dce@racp.edu.au. So moving on, please. So the other thing is that these candidates, I'm sure you remember, are going to be so nervous, and there is a pre-examination candidate greeting. The candidates need to be very separate from the area where the examiners and the patients and families are. So again, you will need to give documentation to the college of where the candidates are to meet and how to get there. It's also very useful on the day to have some advanced trainees who are able to guide the candidates. If you've got a very large area, make sure it's well signed, but having somebody to greet them at the door or the main entrance as they come in and help them get to where they need to be. And yes, sorry, just to highlight, they should also be aware of where they can contact you on the day of the exam, so that if there is a problem when they are trying to let you know of an incident or a technical issue or a procedural incident, then they need to be able to talk, need to be able to find you in a certain spot. Next slide, please. On the website, there is also information regarding the stationery and equipment. Again, it's a very extensive list and everybody loves putting their exam bag together. I don't think there are any significant changes there, apart from the fact that if you need a medically augmented stethoscope, then that needs to be a pre-exam special consideration. Moving on, please. The dress code, during COVID, we were very lucky to be wearing scrubs and making life very comfortable for ourselves so that we can get down and play with kids on the floor. What we have said, though, is we don't want any hospital logos and no suits, ties or jackets while examining the patient. So you should be bare below the elbows, but you may wish to put your jacket on for your presentation. The other thing is that you are allowed an analog watch, so no smartwatch capability. So I was quizzed quite extensively on this by candidates on the weekend who were like, so can I have like a Casio digital watch? Yes, that's absolutely fine, as long as it doesn't connect to the internet. And I think old school Casios are just fine. Your local hospital directives and policies about wearing watches and being bare below the elbows, that's up to you in terms of what you will allow. I know certainly for our exam, we are very happy for wristwatches and wedding bands, so that's okay. The personal items, mobile phones, must be handed in at the commencement of the exam. The candidates are allowed to receive them back at lunchtime so that they can make a call and touch base with friends and loved ones so that they can feel safe. And then before the afternoon session, again, they must be handed in. Again, you can take water with you, and obviously if you need a bit of a sugar hit, you can take some lollies or something of that nature. Obviously you don't want anything that you're going to be crunching away on, but quiet sweets would probably be fine. And then personal medications such as insulin or Nurofen, Panadol, those kind of things are also fine to be labelled with a Ziplocked bag for you. Moving on, please. Again, I think we've touched on the mobile phones, that's fine. I'm racing through because I am conscious of the time. I'm so sorry. Catering, again, this is something that you can start organising once you're aware of exactly how many candidates will be at your site. We request that patients should be provided morning and afternoon break refreshments. I think most of the families that we have at our hospital absolutely love it because they are fed within an inch of their life. The candidates also have their breaks in a separate area from the examiners and should have cool drinks, tea, coffee, and a light lunch with a vegetarian option, so that it's appropriate for everyone. Examiners, as we've talked about, should be morning and afternoon, as well as a full lunch with vegetarian options. And we can probably accommodate most if there are special considerations for some examiners. So that's appropriate, but we can't do all of the candidates, you know, if they're dairy-free or celiac or whatever, but a vegetarian is usually suitable for most. And we've already touched on the time constraints with the catering. So moving on. And yes, you'll receive weekly emails from the 24th of March, which will basically be a bit of a reminder of what we've spoken about tonight, how to manage things like case sequencing and withdrawals, the bell ringing and the types of clipboards that you need. And then right up to the 14th of May, it'll be your final checks and balances to try and make sure that you're well and truly on track. And next slide. The examiner day books, these are our essentially Bibles of the day because it allows us to record all of the information and serves as backup if there was a major problem with the digital scoring sheet. These are to be posted to your site so that they will be available on the day. And these need to be destroyed at the end of the day. Moving on. Now, I've alluded to this already, but everybody's safety is paramount, and that includes not only physical safety, but psychological safety. So if a candidate or anyone at the examination site feels unsafe, then they should stop and immediately seek help. And so for candidates, if they do feel this way, it's not going to adversely affect their examination assessment. So if they stop, that's fine. It's then if they continue to progress with the exam, then obviously that exam result will stand. Moving on, please. If there are any unusual disruptions, so it affects multiple candidates, such as a MET call or a fire drill, like a code red, where things that would just be the worst case scenario ever. But those kind of things that do affect multiple people, please let the assessment services know. Patients who bring pets or support animals. So I guess that's just a for noting, I would imagine. A patient leaves the examination early or any reported incidents by examiners or candidates. So, and there will be a number to call on the day for support. Next slide. Most of you will know this, but if you know the patient, you are not to be the lead examiner on that case. Equally, if the case, say, is a neurological case and you're examining with a neurologist, guess what? You get to lead the case because the neurologist is not allowed to be the lead examiner there. If there are any conflicts of interest, they need to be reported. And the other thing is, if you know somebody as an examiner and you're worried that your presence may cause distress or negatively affect them, then you should also let assessment services know.
Might jump in quickly there, Nadine.
Yeah,
just if there'll be local examiners as part of the teams, and sometimes the local examiners do know the patients quite well, and so having an understanding of what patients belong to which consultant can be helpful when you kind of sequence the patient, so that you make sure that all the examiners can participate maximally in the exam.
Yeah, that's a great point. Thank you. Okay. We've actually spoken a bit about this already, and I will skip over this in the interest of time so that you can ask some questions. But please do read those special considerations. And it's really important that the candidates know that their mark will not change when we review them. There'll be different outcomes. Okay, so and in terms of reimbursement, we all know that we're doing a lot of this on goodwill and that many people are not being paid for their time, and we thank you so much for doing it. But the patients and patient travel, there'll be reimbursement amounts, which you can see there, which will be pre-allocated, and that will be delivered to you once you have submitted an invoice. And thank you to the college for, it's been about a 25% increase based up on last year. So thank you for that. Okay, I think everyone's sick of my voice. So Drago, you can do this. You can answer some questions. So if anybody would like to put their hand up and ask some questions, please do.
I was going to maybe just have a touch on the IT side of things. One of the biggest things that as the examiners need is good internet access. Some of us manage our internet access ourselves with our own iPads with 5G, 4G access, but some might be wanting to join your local Wi-Fi network. Having an idea of what that's going to look like for them and testing it out beforehand will be helpful. For the digital score sheet, we just need access to the internet and an appropriate browser. A Google Chrome browser is probably the preferred browser, I believe, for the digital score sheet. But I think Safari is also okay, and Firefox works well as well. But a Chrome browser is by far the best one. So if you've got computers set up for them to use for the digital score sheet in the rooms, then making sure there's a Chrome browser on there and that can access the internet will be important. Philippa says we don't have Wi-Fi for any medical staff, which case that's really important to notify the college in advance so we can let all the examiners that are traveling there know. Remembering it's the responsibility of the traveling examiner, the NEP, or the SEP, to make sure that they're the ones that take care of the digital score sheet. So they're the ones that really need to have that access and be confident of that access. All right, I guess we're going to open up for questions now. Yes, is public Wi-Fi okay rather than staff Wi-Fi? So long as it's fast enough and support, the digital score sheet doesn't use a lot of bandwidth. So I've found that people, when they've used the public Wi-Fi at our hospital, it's been adequate for them to use a digital score sheet.
Vanessa, I examined in Launceston, I think last year, and I think I used my own 5G because it was difficult to get on. So it might be worth just letting people know as well that your national examiners, they probably just need to link to their own phone because it was pretty clunky, I'm afraid.
Also, if there are any dead spots that you know of in your outpatient area, it's probably worth knowing about that and letting people know. But not as much you can do about it, but make sure we've got contingencies in place.
Any other questions? Like the candidates that we had at our boot camp on the weekend, you're probably completely overwhelmed. And yes, there is a lot of information and it probably seems like a huge task. I'm not lying, it is a huge task, and thank you for taking it on. But it will become much more clear as you get used to looking through the material. Please use your regional examiners. Please reach out to the national examiners in your state if you have any questions. So we are here to help.
Do strongly recommend you do work together. If you've got some sites that are close by, like in Victoria and in South Australia, we've tried to make sure that across the different sites that we're sharing patients. And I think it's really important to help support each other through this. It's a little bit harder for those very regional centres like Mackay and and other places like that, because you don't have other teams to borrow patients from. But I think everyone working together, it's really important that we support each other, because it is a big task and we appreciate all the hard work that goes into it.
Yeah, absolutely. Okay. Stefan.
Yeah, just want to check in. So I'm PEDS director here in Mackay and will be the regional examiner, but thought to sit into the session, even though I'm not the LEO, really want to wrap my head around the process. Last time I was involved in these sort of examinations were back in South Africa a little while ago. So I haven't been through fortunately haven't been through the RACP process myself. Did all my PEDS training in South Africa, but either way, I guess, quick question about the patient selection. Just making sure if I'm understanding that correctly. So obviously we can select patients that the local examiners may know, but it's just ideal in that case they are not the lead examiner, because I thought that's going to be a significant challenge. I heard through a colleague to say you're not supposed to select patients that local examiners know, but I'd say Mackay is a big regional centre, but it's still small enough that we all essentially know all the kids with very good clinical signs and interesting things going on. So yes, they just should not be the treating consultant and lead examiner.
Okay. Yes, absolutely. And I think it is really challenging, because obviously you see these patients when you're on ward service. I think if you can make sure that their usual consultant isn't part of the team that is examining that particular patient. So, I mean, obviously there's always going to be, times where you have to sub a patient in at a different spot. But if you can avoid their usual treating clinician being on that particular team, that's ideal. And yes, the national examiner in that situation would be the person to lead the case.
And as we kind of, Nadine mentioned as well earlier on, trying to make sure that if it's a specialty, like if it's a neurology case, not to have a neurologist there, but you can't avoid sometimes these things. And I've been in situations where it's been my specialty and the patient, there was planned to do the long case, but I then go, oh, I can't do this one, I'll sit this one out. And the other examiner has had to take on that role. So usually at the start of the day, we work out who's going to be doing what during the day, whether the national examiner does the long case in the morning, and then we usually swap around and do swap them around in the afternoon. So, but yeah, we can change those who does what during the day to suit the situation, but we'd rather not sometimes.
Okay. Unfortunately, we've gone 15 minutes over time, but is there anything else that we can answer quickly for you? If not, then the DCE for all exam-related inquiries are always very helpful and able to usually manage all of your curly questions. There are some helpful links there: the RACP Trainee Divisional Clinical Examination, Paediatrics and Child Health, the training resources, our education policy, and the Wellbeing and Support program. All right, well, thank you all. Really appreciate your time, and thank you for putting your hands up to do this job. We and the trainees really appreciate it. So thanks, everyone.